Thank you for the opportunity to present our study regarding the long-term clinical implication of SAM after mitral valve repair. So we spoke about this a lot in the morning. So the incidence of SAM is approximately 10%. Usually most cases are treated medically in the OR, and in most cases they disappear, as was shown before. In the paper from the Mayo Clinic, they reported about persistent SAM in only 2.3%. Also, we know the degree of the transient MR correlated to the SAM can stratify patients into good or long-term prognosis, as was presented in a paper 3 years ago. Regarding the mechanism of the development of SAM was spoken, we are telling about the tall posterior leaflet, the small left ventricle cavity, the closed mitral aortic angle, and the location of the coaptation point that is much closer to the septum. The objective of our study was to evaluate the long-term effect of intraoperative SAM after mitral repair. We had two groups of patients. One patient developing intraoperative SAM, and all other patients without SAM. All patients in group 1 underwent stress echo in the late follow-up. So over a time span of 6 years, we had 393 patients undergoing mitral valve repair due to degenerative mitral valve disease. We had all the operative and medical records, we collected the data prospectively, and we made follow-up by patients' interview, latest echo data, and all patients in the SAM group underwent a stress echo. So from the 393 patients, 30 patients, slightly less than 10%, had an intraoperative SAM. If we are comparing the patient data, the SAM group and the non-SAM, we can see that there was no difference in all parameters between the two groups. Next, we look at the operative data. Regarding the location of the posterior of the mitral valve pathology, there was no difference if it was a posterior leaflet pathology versus anterior or B leaflet. Regarding the repair techniques, also the repair technique was similar between both groups in terms of leaflet resections and using artificial chorda. The ring size was also similar. Regarding the selection of the ring or the band, there was no statistical difference, but we can see that we used more the open ring in the SAM group, and this was because of the intraoperative TE, that we knew some patients had the tendency to develop the SAM, so we were more had used the open ring in these groups. So all the 30 patients in the SAM group in the operation room after going off bypass were treated by the regular treatment by fluid administrations. We tried to withdraw the inotropes and afterload increments. And in most of them, it was almost resolved and the MR was no more than mild. However, in 10% of the patients, they required a second pump run and the ring was replaced from closed to open, and then we had no more than mild MR. Regarding the early results, we can see the mortality and the cardiovascular complication were similar between the two groups. Regarding the late results, the follow-up was approximately 2.5 years. The mortality was similar. Reoperation was similar. The patients that underwent reoperation in the SAM group was not due to SAM. The function class ejection fraction was similar, and also the cardiovascular complication were similar between the groups. So now we went to the regular echo, and the mean MR was similar, and also the distributions in the grade of the MR. We can see that approximately 90% of the patients were freedom from moderate MR and above in both groups. So now we took all the 30 patients, and all of them underwent stress echo. So the average boost stage was 3.3. The maximal heart rate was 133, which was about 82% of the predicted maximal heart rate. The LVOT gradient was low, 5, but the standard deviation is 17. Only 2 patients had gradient of over 20 millimeters mercury. Regarding the distribution of MR, we can see only 2 patients had moderate MR, all others were below, and we had 1 patient with moderate MR due to SAM with a gradient of approximately 65. So if we want to conclude, regarding the intraoperative reversible SAM, the incidence is low, as was published before. We saw no effect on the late right valve repair durability. There was no late negative effect on the functional class of the patients. There was no clinical significant effect in rest in an exercise, which is different here. and we can conclude that SAM-related mild MR can be managed conservative in the OR. Thank you.
I think it's a pity you didn't show us your SAMs, because you may have little SAM and you get out of it, and it looks like you had very little protrusion of the anterior leaflet because the gradients, even in exercise, were so low. So I think it is a real problem. If we had cases now with a gradient of 65, like the one Randy has shown, the outcome would be different. I think you have a good perform quite well to avoid SAM, and it shouldn't most likely be so significant early on to obstruct the outflow tract.
I totally agree. Most of the patients, or almost all 30 patients in this group, the gradient in the OR was low. We didn't see any gradient over 50. And we had only one patient with significant gradient. In the post-op, it was below 50. In the stress echo, it went up to 65. And this patient has moderate MR. It's one patient out of the 30. I totally agree that this patient may come back to us one day, and it's not the typical, the hard SAM that was presented in your case or in other cases presented in the morning.
Just one thing wasn't mentioned this morning because Carpentier was in the room, but if you smell the SAM and you have a big room, it's sometimes quite easy to do one arterial stage, A2, P2, and you won't see a SAM. I personally practice that, and I know Alfieri does it quite some time. So this is really helping.
So you're saying that if you're in the OR and you see SAM, that you'll do.
If the valve is big enough, and you won't create. We all know now for 15 years that the Alfieri stitch really doesn't kill patients. It rather preserves sometimes. The valve, and if you have a problem with your, let's say there is a 35 millimeter ring or you do have a band 34 millimeters, and there is a kind of SAM, I think just one stage A2, P2, and problem is solved, and you will avoid the protrusion of the anterior leaflet into the LVOT, and the office area will be still big enough.
That's interesting.
Can you just say explicitly what would make you go back on bypass and alter your repair? You said you did that in 3 patients, so if you just tell us the criteria.
The criteria was
based on echo or hemodynamics or whatever.
The criteria, usually we went off bypass, and if we saw MR that was moderate or above or even mild to moderate, and there was evidence of a gradient in the LVOT. So we tried the conservative management, give the fluid administrations, usually reduce the heart rate, and then to see what happens. If the gradient was below 30 and the MR was no more than mild, so we can go home. But if the gradient was high and the MR was mild and above, then usually in those 3 cases we went and we replaced the closed ring to an open band. So mostly I would say the decision is the amount of MR.
Did you look at the time of day that the complication occurred? I was laughing with Fred. If it's 5 o'clock in the afternoon, 2+ doesn't look too bad.
Yeah.
I'm sorry to delay everybody's lunch, but it's rare that we get such an opportunity to ask the speakers. So for the 2 surgeons on the group, I'd like to throw the question back at you, Dr. Anu, and just ask you, and also Dr. Moore, what are the situations in which you would go back on and fix, let's say, mild or moderate, and in which pathology and how much is the gradient, et cetera?
I would always go back. If I see a SAM, I would always go back and find a solution, because there was a surgical mistake in the way the valve was repaired, and I wouldn't rely on kind of better outcome later on. And if you have an intraoperative TE right away and there is a SAM, I think we need to do something. Whether you shorten the cords, reduce the height of the posterior leaflet, do an Alfieri stage, whatever. I think you can. That depends really on the case, but First thing, I think you need to train your people that they avoid SAM by the correction by itself. This is the first thing. And if it occurs, they should call a more experienced surgeon who can really quickly solve that problem.
Actually, the next presentation is from our group. We're going to touch on that, but we also have a very low threshold for intervention.
Just even at 5 o'clock running.
Yes, a lot of the time it happens at 5 o'clock in the evening.
Just a very short remark, since I'm a part of this study as well. What Dr. Spiegelstein had presented is cases when you end up with SAM, you have mild to moderate MR. You treat them conservatively. You give them fluids. You slow down the rhythm. You increase the afterload. And then you end up with very mild gradient, with mild MR, maximum mild MR. And you say, that's okay. I'm leaving the OR. So, but you still feel that you don't know what will, because it's not a regular hemodynamics in the operating room, because you're treating them with the very artificial methods. So we wanted to see if those patients, those 30 patients that we left them, that they had a tendency for SAM and mild MR and small gradient in the operating room, does it have implication in the future? And we didn't emphasize it very well in the paper, and you're right, but I think this remark is important. These are the subgroup of patients.
Okay, I think it was a very nice talk.
Thank you.
Thank you very much.